Do you hear me?
Yes. Do you hear me now?
Okay. Hi, Dr. Zamarini. How are you doing?
I'm good. How are you?
Good. Thank you for volunteering your time yet again for us. I really do appreciate it. I do apologize for the moment ago. I didn't know if you could hear me or not. So right now, you're seeing on the right-hand side of your computer um, the bar, right? The action bar with all the different things. I'm going to make you an organizer.
Okay.
I'm going to change your role. Give me 1 minute. Hold on 1 second. So I'm making you a presenter. So because I'm making you a presenter, then you'll be able to share your screen with the audience members. So right now, because I shared it with you, then this is
Yeah.
where we'll practice so I could see your PowerPoint. So not yet, I don't see your PowerPoint. So maybe bring it
Okay.
up and yeah.
Uh,
Oh, there we go. And I encourage you now, if you have any personal emails, files, work, anything to exit all out, or, because you don't want people seeing private, your personal private or your work information. So just close out all your information, your emails, things of that nature. So I see this perfectly. Beautiful. I see your web. Yeah, close anything that you don't want people seeing. Okay, so we're gonna you'll go into slideshow on the top on the where the red bar is. You'll see in white it will say slideshow. You could click on that. It's on the upper.
I'm looking for what you're referring to.
So if you see, I'm seeing your screen right now. So I'm seeing red on the on the very top of your PowerPoint. You'll
Yeah.
see there's a bar. It's all red, and on that bar, um, closer to the left-hand side, you'll see it says slideshow in white.
Yeah. Okay.
Your browser is almost over there. It spells out. Yeah, put your browser on the slideshow.
Yeah. Just a second. I'm trying to switch. It's not switching. Let's see. I may have to. So I may have to switch screens. Just a second.
Take your time. This is why we have people come on a bit earlier, so to ensure technical difficulties are limited. That's not a problem.
Actually, um, let's see. It's just think. Hold on. No, not yet.
When you were on it before, I saw everything perfectly. All you needed to do in the red bar was hit slideshow. So, you obviously know your platform and computer better than myself, but I just wanted to let you know when you were on the other screen, I saw it perfectly.
Okay, I'm trying to undo something I just did.
Oh, okay, take your time.
Let's see. Uh, okay, what are you seeing now?
Right now I'm seeing it says go to webinar. I see it
Okay.
says connected to go to webinar.
I'm trying to because I have three screens. I'm trying to switch the screen that shows up.
Okay.
I used to be able to just toggle between them. I'm not sure why they're not. Oh, okay, maybe this will do it then. Let's see. Um, let's try that. No, it doesn't change it.
I see disclosures, receive research
Yeah.
support from
Okay.
NI. Is this your
Okay.
PowerPoint?
Yeah, that's the PowerPoint. Um,
So let's go to the first um, slide from the beginning.
here.
Yeah, there we go. Perfect. Okay,
Okay.
so what we're going to, excellent. I'm happy you figured that out. You must have a billion screens because you have so much going on. um, I have one screen. I'm not as important as you. Maybe if I get like on your level, I'll get a couple more screens. But I
Yeah.
understand. So I'm happy that you were able to figure that out. Excellent. So it's
Yeah.
12 here Eastern time. It's 12:39. So I'm
Yeah.
gonna what's gonna happen is just like you did it before. At around 1 o'clock, I'm going to introduce you. Give a little background of who you are, and then I'm going to let you know to take the lead. This is going to be in listen only mode. So just like I know you've done this before for us, the individuals will type in questions at the end and I'll read them to you. Um, and so from now until we start, I'll mute my phone and you'll mute your phone. And around 1 o'clock, I'm going to start a couple of minutes before 1. I'm just going to let everyone know that we're waiting, that this presentation will be in listen only mode, that on the right hand side, you will type in questions or comments, and at the end, we'll read them. I'll also let them know that this is available, the PowerPoint and PDF as a handout. Um, and that's basically it. Do you have questions or concerns about today's presentation?
No.
No.
Um,
Right
I'm,
now, though, what I'm seeing in the screen, it's like you might want to take it back to how it was before because I'm seeing like two, the beginning our care connection slide, and then I see your next slide. So maybe you want to put it
okay.
how it was in the back, just a regular slideshow, um, because the people, if they're on, will see this format. Yeah, just like that.
So right now
Do you
you're
want
just
to?
seeing the slide care connection.
Yeah, go to the next one and see what happens.
Yeah, exactly.
Okay,
Okay.
perfect. Okay. Yeah. So leave it on the landing slide. It's 12:41 at around 12:52, 12:53. I'm going to start it, but I'm not going to have you speak. I'm just going to let people trickle on, give them the information, and then at 1 o'clock we're going to go live.
Okay. Very good.
All right. Thank you. So you could put your phone on mute, and then you'll hear me. After I introduce you, you'll unmute yourself and start speaking.
Very good.
All right. Thank you. Hi, good afternoon, everyone. Welcome to Care Connection. We're going to be starting in a couple of moments' time. Just while we wait, I want to let everyone know that we will be in listen-only mode, and for questions and comments, you will have the opportunity to type them in on the right-hand side under questions in your toolbar. We will begin in a couple of moments. So again, we will be in listen-only mode. We will be taking questions and comments at the end, and you could type them in on the right-hand side. Good afternoon, everybody, and welcome to Care Connection, the free live webinar, the second Thursday of each month. Today, we have a very special guest speaker. His name is Dr. Edward Zamarini. He is a board-certified geriatric and cognitive neurologist with over 25 years' experience in clinical management of Alzheimer's disease and related disorders. He has been a principal investigator on dozens of clinical trials and has given hundreds of talks and published dozens of peer-reviewed articles related to memory and dementia. He is a director of memory disorders at the Cleo Roberts Memory Clinic at Banner Sun Health Research Institute. Today, he will be speaking about clinical trials and what they are all about. Before we begin, I want to let everyone know that for this presentation, it will be in listen-only mode. That at the end of the presentation, you will be able to type in your questions, comments, or concerns on the right-hand side under questions. In addition, this PowerPoint will be provided in PDF format under handouts on the right-hand side. So Dr. Zamarini, please begin your presentation.
Good afternoon, everyone, and thank you for being here, and thanks to the Alzheimer's Foundation of America for sponsoring this talk today. I'm going to be giving a primer on clinical trials, if you will. First, I just want to give you some disclosures that I do a lot of clinical trials with various pharmaceutical companies, but our center is also supported by the NIH, the state of Arizona, the Sun Health Foundation, and Banner Alzheimer's Institute. So I'm going to give you a little bit of a background about Alzheimer's disease and then dive into clinical trials, why they're important, how they work on a practical level, and then if you're interested in getting involved in a clinical trial, how you might be able to do so. So one of the first and most common questions I get asked is this dementia or is it Alzheimer's disease? It's a little bit like asking, is this a cough or is this pneumonia? So pneumonia is a specific cause of cough. Cough is a general symptom. Dementia is a set of symptoms called a syndrome where there's loss of everyday skills with impairment of higher mental functions, including memory, language, judgment and personality changes, visual-spatial functions such as recognizing people or recognizing places or things, and other cognitive abilities such as being able to handle one's finances. Now, dementia is a general term and does not indicate what the cause of the dementia is. There are numerous causes of dementia. Alzheimer's disease is one of many causes of dementia, but because it's by far the most common cause, this is why we hear so much about Alzheimer's disease. But typically, if someone has Alzheimer's disease dementia, then they do have dementia due to Alzheimer's disease. If someone has dementia, it could be due to Alzheimer's or due to something else. It's important to remember that. But because Alzheimer's in the elderly is probably responsible for more than two-thirds of the cases of dementia, therefore, if we impact Alzheimer's disease, we impact most of the cases of dementia. Now, when I first started seeing patients with dementia approximately 30 years ago, I would see them towards the end of their lives, when the caregiver would bring them wanting to place them in a nursing home. The caregiver would come in with bags under their eyes, tearful, saying, "I can't handle this anymore. Here, take him. I just can't take it anymore." Thankfully, around that time, the first drug for Alzheimer's disease was approved, and so we started seeing patients with Alzheimer's a little bit earlier in their dementia course, say in the middle stage here, if you will. And then with time, more drugs started to get approved, and we started seeing patients at an earlier stage. Now, when I first started seeing patients with dementia, people were either considered to be aging normally or to have dementia. There was no middle ground. Over time, we figured out that, well, you don't go from normal aging to dementia, which is the severe impairment where there is functional impairment in activities of daily life. You don't go from one to the other overnight. It's not like an on-off switch. It's more like a dimmer switch. And so the concept of mild cognitive impairment being an intermediate stage came up. And you'll recognize in a moment why this stage is so important. But basically, mild cognitive impairment is a nice descriptive term. It's mild, therefore it's not at the level of dementia, but there is cognitive impairment nonetheless that is beyond what is expected for normal aging. Now, in normal aging, we all forget somebody's name once in a while, or we all may forget where we placed something, again, once in a while. When it becomes more persistent, and it starts to increase in frequency and severity, then there's an indication that something is wrong. And neuropsychological testing, that special pen and paper testing, can help confirm if this is no longer within the range of normal and has reached the stage of mild cognitive impairment. Also, looking at this course of events, we can divide patients with dementia as mild, moderate, or severe. And then patients with mild cognitive impairment can also be divided into early mild cognitive impairment and late mild cognitive impairment. And people with normal aging can be divided in those who are asymptomatic and those who have subjective symptoms that are not severe enough to show up on pen and paper testing. And so you can see as the years have passed, we've become more sophisticated in how we subtype people within this continuum. And this subtyping is really a matter of convenience and nomenclature, so that whenever we talk as researchers or clinicians with each other, we kind of understand where on the spectrum a person lies. And that becomes important as we try to select patients for clinical trials. Now, mild cognitive impairment is a stage where there is objective evidence of an acquired deficit. That's to distinguish it from subjective evidence of impairment. Subjective would be somebody saying, I'm more forgetful than I used to be, I'm concerned about it, but then when they go through detailed testing, they're okay. If they are not okay, if they're beyond 1.5 standard deviations of the norm, then they're considered as having objective evidence of an acquired deficit. The prognosis for people with mild cognitive impairment is variable. And so it's really important to remember that, because some people with mild cognitive impairment, or MCI for short, will go back to being cognitively normal. Some will continue as having mild cognitive impairment the rest of their lives without deteriorating much further. And some will continue to deteriorate and develop Alzheimer's disease at a rate of 12 to 15% per year. So it's important to recognize that even if we identify someone as having mild cognitive impairment, we kind of have to do a little bit more testing before deciding if this person is at greater risk of progressing towards Alzheimer's disease. And just as there are many causes of dementia, Alzheimer's being one of them, there are many causes of mild cognitive impairment, again, Alzheimer's being one of them. So as we contemplate where we've been and where we're headed with trying to combat Alzheimer's disease, it's important for us to recognize the cases of Alzheimer's disease that are pre-dementia stage, the MCI cases. And it's important for us to look at how might we be able to prevent the onset of Alzheimer's disease, or if we can't prevent it, delay it. Even a delay of 1 year would have major significance over the coming decades with regards to people's health and how many people end up in nursing homes. So what's the basic pathology of Alzheimer's disease? What are we going to try to tackle in order to slow down Alzheimer's disease or delay dementia due to Alzheimer's disease? Well, Dr. Alzheimer described the clinical case of a 51-year-old woman who progressively became more and more demented, and then ultimately died at the institute that he was practicing in. He then looked at her brain under the microscope and saw these tangles and plaques. So these are the tangles, these are the plaques. And in modern day, high magnification, nice color pictures, you see the plaques and the tangles. The tangles tend to be inside the cells. The plaques are large and are outside the cells, and often mess up the cells around them. And it's also become obvious that with Alzheimer's disease, as cells die, the brain shrinks. Now, one way of thinking about this continuum of disease is to think of people who are already symptomatic with dementia in this gray box, people who are symptomatic but have not reached the stage of dementia and who are in the MCI stage in this pinkish box. But then you have people who are cognitively normal on the left side of this graphic. Now, if we want to try and slow and treat dementia, we've come to understand that the best time to treat it is before it starts. So our two options are to treat it when symptoms have started but have not progressed to the stage of dementia, or ideally before any symptoms start, in the hope that we can prevent symptoms in the first place. So that is trying to target people who are cognitively normal. Now, in the box of people who are cognitively normal, not everybody is at risk of developing MCI and dementia. So it doesn't make much sense to include people who are at low risk of developing MCI or dementia. And therefore, we have to target our efforts in clinical trials, in prevention clinical trials, at the stage of cognitively normal, ideally, but target people who are more likely to develop MCI and then dementia. So we can think of things as symptomatic treatment. That's when people have MCI or dementia and where the drugs help symptoms but do not alter the disease. Drug modifying therapies, where we are trying to modify the disease and slow it down, and preventative therapies, where we're trying to prevent disease in the first place. So we have to be able to shine a light and figure out who is at greater risk of developing MCI and Alzheimer's disease. Well, how might we do that? And the answer is by the use of biomarkers. Biomarkers are biological markers that allow us to tell who has more risk factors for developing Alzheimer's disease pathology. In a way, you can think of it as, well, if you go to a clothing store and you look at the tags that are attached to each clothing item. The tags will tell you if this is for someone who is large or petite or medium. The tags will tell you what kind of fabric it's made of. The tags will tell you about the cost. And so similarly, when we're trying to think of making a diagnosis of, or refining a diagnosis of dementia, or looking at the people with MCI or cognitively normal who are at greater risk of developing Alzheimer's disease, we have different tools that we are studying to try and see who is at greater risk of developing Alzheimer's disease. Some of these tools can be fluid biomarkers, and hopefully one day we will have a blood test to look for markers of Alzheimer's disease. Recent data suggests that our current efforts are promising. We can look at other fluids, such as the cerebrospinal fluid, and learn about particular biomarkers of interest, like how much amyloid is in the spinal fluid and how much tau is in the spinal fluid, since both amyloid and tau are characteristic proteins involved in Alzheimer's disease. We can look at structural imaging, like volumes in the MRI scan. We can look at functional imaging, such as using functional MRI to tell what parts of the brain are not functioning appropriately. We can also look at fluorodeoxyglucose, or FDG PET scans, which are special kinds of PET scans that tell us how healthy are the cells and how are they functioning in a healthy manner. In this particular figure, we see what's called the thumbprint of Alzheimer's disease, where the parietal lobes are affected and they're not lighting up with yellow and red like the other areas of the brain. We can also look at genetic risk, such as the apolipoprotein E4 gene, which seems to be associated with a greater risk or doubling of the risk of getting Alzheimer's if you have one allele or one of the genes, and quadrupling the risk if you have both alleles. So if a person is ApoE4, meaning that they have both alleles for the ApoE4 gene, they're at significantly greater risk than somebody without the ApoE4 gene. And finally, we can look at amyloid PET scans, which are approved by the Food and Drug Administration, and tau PET scans, which are still research scans, and we're still trying to figure out how to best interpret the various tau compounds and see which one might ultimately end up getting approved by the Food and Drug Administration. In brief, there are many ways where we can look at the risk for developing Alzheimer's disease. One of the ways, as I mentioned, is to look at amyloid PET scans. Now, how do we know that amyloid PET scans reflect reality in the brain? One such study was done at our center at Banner-Sun Health Research Institute, where we looked at brains of people who had received PET scans and died soon afterwards. And we looked at how well does the amount of amyloid that shows up on the scan correlate with the amount of amyloid in the brain. And as you can see from this image, the more the brain lights up with amyloid, the more brown particles are seen on the images. And so there's a good correlation. And so this particular scan compound was approved by the Food and Drug Administration. And it's now accepted that we have 3 approved markers of amyloid in the brain in the living person. These kinds of scans have allowed us to track people over time and repeat the scans over time and look at what happens to the brains of people, for example, who have a very rare form of Alzheimer's disease that is hereditary. This is a particularly rare form of the disease. However, it does allow us to look at carriers, people with, who are at risk, and track their amyloid scans and see that amyloid deposits a decade or more before people show symptoms of the disease of dementia. And so by armed with this information, we can then start targeting people who have amyloid in their brain but are cognitively normal to try and prevent onset of symptoms due to Alzheimer's disease. Now, amyloid doesn't just form plaques right away. Amyloid starts off as an amyloid precursor protein that is a transmembrane protein. That's a protein that crosses the cell membrane of the nerve cells. And depending on how this protein is cut, it may form soluble, harmless particles, or if it's cut in the wrong place, it may start to clump together and form what are called oligomers and then fibrils and then deposit as plaques in the brain. So when we're trying to get rid of the pathology of Alzheimer's disease, we can either target the plaques and try to remove them, target the oligomers and the fibrils and reduce the formation of plaques, or target where APP breaks down in the wrong place and try and reduce the formation of these peptides and oligomers and hence ultimately plaques. So one type of drug is a drug that removes or reduces amyloid plaques. And these are immunologic monoclonal antibodies. These are specially formulated compounds that tack onto the amyloid and help the body remove the amyloid from the brain. And one such compound called Aducanumab, there are others, by the way, it's not the only one, and it still is experimental, has been shown to reduce the amount of amyloid in the brain. What is lighting up? There is less amyloid lighting up in the brain of this individual at 54 weeks. And so this is encouraging data that the compound does what it's supposed to do. It engages its target. And in a small study of a small number of individuals, we see that the longer they're exposed to the compound, the more amyloid reduction there is. And the higher the dose used, the more amyloid reduction there is. So this is quite encouraging that we can reduce amyloid. Now we have to figure out, does this reduction result in significant cognitive improvement? And at what point can we start targeting people? Should we start after the dementia stage has started, or when they're still in the MCI stage, or can we target them when they've started to have amyloid deposits without symptoms? So how can we clear the fog in our struggle to beat Alzheimer's disease? Well, we have to do clinical trials. And when we do clinical trials, we have to look at the placebo effect and false flag effects, among other things. And this is really important because we have to figure out if our compounds are better and safer than not doing anything. So, what's the placebo effect? A placebo is an inactive pill or treatment. And we typically have people who are on an active treatment and people who are on placebo. And then we compare those on active treatment and those on placebo. For instance, yesterday I saw the results of a patient who is being followed in a longitudinal study where there is no treatment involved, yet that patient developed cancer of the prostate. Now, if they were on a study, how would we know if this compound is causing cancer of the prostate or if it would have been a natural event? Because we're studying people who are elderly, and just by the fact that we're studying that group of people, they are at risk of developing side effects, such as this one patient. So we have to be able to compare incidence of any event in the people who are receiving treatment versus the people who are receiving placebo to determine, number one, is the drug responsible for more side effects? And number two, is the drug actually safer than not using the drug? Sadly, in some recent reports, we've had a class of drugs, one particular study show that a BACE inhibitor, patients on the BACE inhibitor did slightly worse than people on placebo, and so the drug was pulled. If we hadn't been studying placebo, we wouldn't have been able to tell if the drug was actually producing a benefit versus possibly producing a minor harm. The other thing we have to be aware of is false flag culprits. So I'm going to tell you the story of one of my sons, and that helps demonstrate this. So I was on vacation in Mexico with my two sons, and the last evening, my son was throwing up all night, my son Omar. And so I felt really terrible, and I tried to figure out, well, we all ate the same thing. How come he has food poisoning and his brother and I don't have food poisoning? And I offered to take him to the hospital or to see a doctor, and he adamantly refused. And so we kind of rode out the night. The next morning, as I was packing up my bags, I saw a half-empty bottle of vodka that Omar had drank the night before. And so that was the explanation for his throwing up, and it wasn't something I had considered during the night. So having placebo-controlled trials and having well-thought-out trials allows us to be able to figure out what's causing what. Clinical trials typically are in multiple stages. They have 4 phases, and we can have different types of clinical trials, those that are randomized and those that aren't randomized, those that are blinded and those that are unblinded, those that involve some participants and those that involve many participants. Some can be over a short period of time, some can run over years. So let's look at these aspects. So clinical trials run over multiple stages or multiple phases. Phase one is when a new compound that looks promising in the lab is first tested in humans. Typically, it involves only a few people, and we're mainly looking at safety and also looking a little bit at what dosage should we use. And is the dosage that we're trying to use safe? In phase two studies, we're looking at larger groups of people. We're also still mainly concerned with safety, but are starting to look at, do we see any kind of signal? In phase three, that is when we're using large groups of people and trying to look mainly for effectiveness of the drug, but at the same time, we continue to monitor for side effects. Phase 4 studies are after the drugs are already approved by the Food and Drug Administration, and they continue to be monitored to see, once they are used on a large scale, if any new information arises. And there are situations where once drugs have reached the phase 4 stage, have already been approved by the FDA and used for over tens of thousands of people, new symptoms show up related to the compound. If these new symptoms are relatively mild, then it's easy to handle them. On a few occasions, those new symptoms turned out to be serious enough that the drugs were pulled from the market. And one could not have predicted these kinds of side effects from phase 1, 2, or 3, despite due diligence. Now, randomization is very important in clinical trials. In other words, we cannot pre-choose who we put into the active arm and who we put into the placebo arm. We have to randomize people like by a flip of a coin in order to have somebody get either active treatment or placebo. This ensures that traits that could influence the results are equally distributed. A simple example would be if we included all men into the treatment arm and all women into the placebo arm, any differences that are determined could be because of differences in gender rather than due to the effect of the drug. So we also have to be able to blind the studies so that we cannot tell if a person is on placebo or on the compound. So some studies are unblinded, but those are typically when we're first testing the compound, say in a phase 1 trial. Some have a single blind, for example, when the participant doesn't know what they're getting, but the investigator knows, or vice versa. But the best standard of clinical trials is when they are double blind and when neither the investigator nor the participant knows if the participant is getting active treatment or placebo. And that way there is less risk of seeing benefits that aren't really there. As far as number of participants and duration of the study, that depends on the phase of the study. As I mentioned, in phase 1, it's only on a handful of individuals, phase 2 on some dozens of individuals, and phase 3 on hundreds or over 1,000 individuals. The duration of the study depends on how effective the drug might be and also how rapidly the disease process occurs. So many studies involving Alzheimer's disease are long, over 6 months to maybe 2 years or longer, because the disease process itself is so slow, and in order to be able to distinguish effect of drug versus placebo, you have to study lots of people over an extended period of time in order to be able to determine differences. So On a practical level, once a person wants to participate in a clinical trial, they typically have to go through a pre-screening in order to determine are they of the right age group, are they in the right category to be able to be invited into the clinical trial. Once they get invited, they need to review the informed consent, have time to consider it, have time to discuss it maybe with their family and others, and with the investigator or their surrogates, and then they sign the informed consent. Once they've signed the informed consent, they go through a screening process, and the screening process can be a one-time screening evaluation, or it can be a multi-stage evaluation. Typically, in Alzheimer's studies, it's a multi-stage evaluation where it's like peeling layers of an onion. They have to do the first screen, and if they pass that screen, then they go on to the second screen. If they pass the second screen, then they go on to the third, and so on. Then, once they've passed all the screening steps, they go through a baseline evaluation, and they get randomized either into a treatment arm or to placebo. The randomization is important, again, to keep the double-blind process in order not to influence how the study drug and any effects of the drug, positive or negative, are perceived. Then there are a number of follow-up evaluations. Typically, those evaluations occur every 3 months, and at the very end of the study, a termination visit. The evaluations can be simple questionnaires, physical exams, blood tests, imaging tests, neuropsychological tests, those are pen and paper tests, and potentially other kinds of tests such as a lumbar puncture for spinal fluid. Now, depending on the study, it can be any combination of the above. Some studies require PET scans, some don't. Some require lumbar puncture, some don't. Well, you might ask, well, why do a lumbar puncture in the first place? Because the lumbar puncture provides us information that we cannot obtain otherwise, and we cannot simply obtain using PET scans. And in order to determine how well the drug gets into the brain, how effective is the drug, how much of it stays there, and how much does it affect the amyloid and the tau, lumbar puncture may actually be the best test for that. These are done routinely in Europe, but they have not gained as much popularity here in the US. How to get involved? Well, there are many considerations. First of all, one has to determine, well, is this a study targeting Alzheimer's disease or MCI or cognitively normal individuals? Is the person healthy enough to participate in the study? Because if they're on multiple medications, many medications may not be compatible with the drug being studied. Do they have pre-existing conditions, for example, diabetes? If they do, is the diabetes under good control, or is the blood pressure under good control, or not? If they are not under good control, they may need to be controlled first. And then we also need to look at not only prescribed medications, but over-the-counter medications, because even over-the-counter medications may affect hepatic metabolism of drugs in the liver. And then most studies nowadays for Alzheimer's disease require a study companion because we need an observer that may notice things that the study participant may not notice. Finally, when we're considering participation in clinical trials, we need to also consider what are other issues that may impact us. For example, Does this study involve a treatment, or does it not involve a treatment? Is it just an observational study? No treatment is 100% safe all the time. If you drive your car, no car is 100% safe all the time. So similarly, with drugs, there can be side effects. And so one reason people are monitored every few months in a clinical study is to make sure that we put safety first. Typically, by the time drugs reach the phase 2 or phase 3 stage, they're deemed reasonably safe, and any potential side effects are usually described in the informed consent. Uh, Now, you also need to consider how far is the treatment center. If it's 100 miles or 200 miles away, are you willing to make the trip for each visit? How frequent are the visits? Some people say, well, I can come in once a year, but not more often. And so an observational study might be more appropriate in that situation. How long are the visits? Typically, the visits are anywhere from 2 to 4 hours. Sometimes they take up 6 hours or even longer. And so you have to factor that in. Is this a commitment you're willing to make? Is this okay with you and also your study partner? And you have to decide your own preferences. Some people want to be on a treatment trial because they want to maximize their chances of delaying Alzheimer's disease. Some others may not want to be in a treatment trial. They don't want to take any pills or drugs. And so they might want to be in an observational study and still help us find better treatments against Alzheimer's that way. And some studies involve pills, some studies involve intravenous drugs, or drugs administered by other means. And so you have to look at your own preferences as well. So how might you be able to find studies that you might want to participate in? Probably the most prominent website is clinicaltrials.gov, but I've also listed a few other sites that are on a national basis and that can help direct you or provide you more information about clinical trials. There are clinical trials for cognitively unimpaired individuals, and some of these are registries or observational studies or treatment trials. You can again go to clinicaltrials.gov and look at what is of interest to you. Some studies are available for patients with mild cognitive impairment, and there are also different kinds of trials: observational, involving drugs, involving other strategies to try and delay Alzheimer's disease. And then there are also studies that I haven't listed here for patients with mild to moderate Alzheimer's disease or for behavioral symptoms that tend to occur in Alzheimer's disease. Regardless of whether you do participate in a clinical trial or not, we recommend that you maximize your brain reserve. Brain reserve refers to the number and volume of brain cells. How healthy are your brain cells? And how many connections between brain cells are there? The more connections would have to be lost before symptoms start. So brain reserve is one way of maximizing your chances to delay Alzheimer's disease. How do you maximize brain reserve? By applying common sense health measures. Typically, things that are smart or good for your heart are good for your brain. things like physical exercise, eating a healthy diet, sleeping adequately, and minimizing stress. And if you're a smoker, quitting smoking. Other things are also good for the brain, such as keeping your brain active or mental aerobics. And here I emphasize, please do mental activities that are pleasurable, like reading or puzzles, the kinds of puzzles that you like. Uh, by the way, watching TV, even educational programs, is considered passive and not a mental exercise. Social activity, such as meeting with friends, going dancing, going out to dinner, having discussions, is considered also protective. Finally, watching your blood pressure, blood sugar, your cholesterol, and other lipids, taking good care of your general health is also going to help protect your brain. So we recommend doing all these measures anyway, whether you participate in a clinical trial or not, to help minimize your risk of getting Alzheimer's disease. Now, there are many studies going on against Alzheimer's. In fact, there are over 100 currently active studies. It's important to keep things in perspective, that even though our best intentions are to find drugs to help against Alzheimer's and help minimize symptoms, in one recent study using a drug, verobecestat, the results showed that patients on the drug actually did slightly worse than patients on placebo. Now, for all intents and purposes, this is a drug that blocks the breakdown of amyloid precursor protein in the wrong place in the hope of minimizing the amount of amyloid. And indeed, it looks like it does minimize amyloid, but it might do too much of that. And so we have to learn more about the drugs that we want to test and figure out what are the safest ones, and if we encounter unexpected things, what can we learn from those studies in order to come up with better strategies. And this is what scientists constantly do. The other thing I want to tell you about is I often get people tell me, well, Doc, what about the study that cures Alzheimer's disease? And then I ask them for details, and they say, yeah, it's been studied in X, Y, or Z country in mice. Well, it's one thing for a drug to show that it engages target in mice. It's a whole other thing once we study humans. And all studies have to be verified independently in order, particularly early on, in order to take them to the next stage and the next stage and the next stage. So it's important to bear in mind that, yes, there's a lot of research being done. There are lots of very hopeful strategies out there, but we have to do our due diligence. We have to be patient, and we have to be methodical in how we progress through the different stages of disease. So clinical trials are really important to help us find new treatments against Alzheimer's disease. Chances are the earlier we start, the better our chances, but we have to be very methodical and very careful and constantly vigilant as we progress through these trials. And before I end and open it up for questions, I'd like to acknowledge the residents of the Sun Cities and the Sun Health Foundation for sponsoring our center, for the banner Alzheimer's Institute, and the Alzheimer's Association that helps that helps us also, the National Institute on Aging, our industry sponsors, the various foundations that help support our research, and all the philanthropic support that we get, including the state support. And most particularly, I want to thank all the people, all our patients, and all the people who participate in our clinical trials. I would also like to acknowledge the Alzheimer's Foundation and its support of education and making this webcast possible. So thank you, everyone, and I'll be happy to take questions.
Thank you so much, Dr. Zimmerini. I certainly learned so much new information. And so we do have a couple of questions waiting. Our first question is, if someone has severe dementia, are there anything we can do for them? Any drug in development? Can they request to get a drug within or outside the clinical trial?
So given that we still don't have any proven drugs that will halt Alzheimer's disease or significantly delay it, currently drugs that are currently in testing are not being used on a basis for for patients with end-stage disease. Unlike, for example, in cancer, there are a number of drugs that can be used at end stage because those drugs are evolved enough or have shown adequate enough results, even though they haven't been approved yet. So they can't be used on a compassionate basis in Alzheimer's disease. Sadly, by the time a person reaches the end stages of Alzheimer's, they are so advanced that we can't do CPR on their dead or dying cells. Now, they might be able to participate in certain types of trials that allow us to learn more about biomarkers, but they would have to agree to autopsy once they die. And these drugs typically are not treatment drugs or treatment markers. They're more markers to help us understand the disease better, and if we can find better ways of detecting it at earlier stages.
Thank you. We have a question from Laura. Can investigators tell you what phase the drug is in before you sign up for a trial?
Absolutely. They should tell you, and you're perfectly within your right to ask if they have not told you. So clearly in a phase 1 trial, that would be part of the informed consent. Typically, also in the informed consent, it tells you if this is a phase 2 or a phase 3 trial. But if it doesn't tell you, you're perfectly within your right, and I would encourage you to ask what phase is this study.
Thank you. We have 3 questions from Muriel. The first question, can healthy people also participate in clinical trials? What is the motivation for them to participate in a trial?
Okay, so healthy people can absolutely and most definitely participate in trials. Now, they have different options of participation. They can simply engage, subscribe to a registry where they mainly get information, and they get offered options to participate in trials every once in a while. But there is no commitment on their part to participate in any trial. Second, they can participate in observational trials where they get tested once or twice a year to see how much we can learn about how the brain works over time and how certain things like biomarkers we're looking at behave over time. Third, they can participate in clinical trials where a treatment is offered. Now, for healthy individuals, as I mentioned, people who are healthy and want to participate in a trial, they can be healthy at risk or healthy not at risk. How do we distinguish between the two? That's where we go through the multi-stepped process of screening and look at, well, do they have a biomarker? Then do they have the next biomarker? Then do they have the third or fourth biomarker? And this stepped screening process allows us to select out the people who are at greater risk of developing Alzheimer's. And so that's where their motivation would come in. If they are at greater risk, they would be helping us find preventative treatments. If they are at lower risk, chances are then that they would be selected out, or they would quote unquote screen fail, and therefore they can pat themselves on the back that they screen failed and that they are at lower risk, and so they don't need to be in the study. So simply, screening for studies might be one way they can figure out if they are at lower risk or if they are at greater risk. If they are at greater risk, it's in their interest to help us find treatments to help prevent or delay Alzheimer's.
I have another question. Any good gene which can help provide early warning for Alzheimer's? I'm not sure what the question is asking. Maybe you as a doctor will be a little bit better at discerning. I'm sorry.
Yeah, I'll elaborate on this a little bit. So briefly, there are at-risk genes and there are deterministic genes. Thankfully, in Alzheimer's disease, the deterministic genes are extremely rare. Deterministic genes means that if I got a particular gene, even if it's only one copy of that gene from either parent, I am doomed to get Alzheimer's disease at some point in my life. Thankfully, those are really rare, but families who have those genes are being identified and invited to participate in clinical trials. For the vast majority of people, Alzheimer's disease occurs sporadically. In other words, there is no obvious way of telling who's going to ultimately get Alzheimer's disease. Now, we're doing studies to try and figure out who is at greater risk, but one has to then undergo specific tests to determine if they are under greater risk. One of those tests is to see if they carry the gene for apolipoprotein E4. Now, it's very important to remember, if a person carries the gene for apolipoprotein E4, they are at greater risk of developing Alzheimer's disease, but they may or may not develop Alzheimer's disease in their lifetime. It's also important to know that if they do not carry the apolipoprotein E4 gene, they may or may not develop Alzheimer's disease in their lifetime. So that is one reason why we typically look for more than one biomarker when we invite people to participate in our studies.
Thank you. I guess piggybacking on that, how can one get tested for genes in North Carolina, in Raleigh, North Carolina?
So there are commercial sites that can test you for the apolipoprotein E4. We discourage people from doing that because, number one, a person with the ApoE4 gene, ApoE4 for short for apolipoprotein E4, they may or may not get Alzheimer's, so that information may have no benefit to that individual, may provide no benefit to that individual. Also, they could go to their doctor and have asked their doctor to test for the ApoE4 gene, but most doctors, including myself, would be extremely reluctant to just get an ApoE4 just like that. Again, because having that piece of information does not advance any therapeutic benefit for that individual. Now, if that individual is interested in participating in a clinical study, they can go to clinicaltrials.gov. It is one of the sites that I showed up on there. It's the site that the government hosts, clinicaltrials.gov, clinical trials, one word, and put in, for example, gene, Alzheimer's disease, and they can look for studies that look at genes and Alzheimer's disease. So the generation studies, generation 1 and 2, are studies where people who are carriers of the apolipoprotein E4 gene are screened and the genetic profile for the apolipoprotein E gene is looked at, but where people get genetic counseling as part of that process so that they understand better the implications of knowing their genotype and what it might mean to them and to other members of their families. So I strongly encourage anyone interested in getting their genotype to actually specifically do it as part of a study.
Thank you. One more question. It says, any gene to differentiate from other dementia forms?
Well, there are other genes that are associated with other dementia forms. It gets very complicated very quickly. If a person is particularly interested in other dementia forms, I would suggest they talk to their neurologist, particularly with a dementia specialist specifically, because this really requires maybe an hour's conversation rather than a minute response.
Thank you. We have a last question coming in from Scott. He's writing, I don't have a reliable study partner and have been turned down by a local study. Are there other studies to try?
There might be. Most studies will require a study partner. So I would encourage you to maybe look at whichever research site is near you. And so you could, for example, on clinicaltrials.gov, say, type in Alzheimer's and whatever city you're in, and see what sites are studying Alzheimer's, and you could contact them and let them know about your particular situation.
Thank you so much. It doesn't seem that we have any other questions. Oh, I'm sorry. I spoke too soon. One more question, and then we will wrap up because I know Dr. Zamarini has a busy schedule ahead of him. So this is the last question. Studies are being done for mild, moderate Alzheimer's disease. Any help for moderate and severe disease?
Yes, typically the studies for moderate to severe disease are more to either try and help basic care of patients, and typically involve much more heavily the care partner, or they end up being for behavioral problems which occur typically or more prominently in the middle to late stages. You have to remember that by the moderate to late stages of the disease, our experience has shown us that we're relatively powerless to try to reverse any aspect of the disease. And so studies for moderate to late are more for symptomatic relief and more for behavioral problems.
Thank you so much, Dr. Zamarini.
My pleasure.
I feel like you've explained this in such a way that's digestible, and I certainly learned new information. And based on the questions, I believe the members also learned new information as well. I want to let everyone know that Dr. Zamarini PowerPoint is in PDF on the right-hand side under handout, so certainly take that along if you want to have it as a reference guide. And I want everyone to know that we'll be back. Actually, we'll be having a special edition webinar program, and that will be on Thursday, November 15th from 1 to 2 p.m. Eastern Time on hoarding and strategies to help with this behavior. I hope everyone has a wonderful rest of the day. Again, a big thanks to everyone who came on, and a big thanks to Dr. Edward Zamarini. Have a good day, everyone. Bye-bye.
Thank you all for attending, and thanks to the AFA for organizing this. Much appreciated.
Thank you.